Yeah, thank you, Professor Ashraf, for the introduction, and it's a pleasure to be in here. So, the next 20 odd minutes, I think I will briefly state something quite obnoxious. On some aspects of genetics and genomics, and some examples on how we could translate this information to a larger perspective at a community level. Now, before I start my talk, I always put up this slide, and there's been quite a practice for the last few years. I'm sure what you know what this is. What is this instrument? An MRI. Okay. What else? It's a CT scanner. Absolutely. Now, CT scanner is actually 50 years old, and if you really look at the perspective of humankind and how medicine has evolved, and I think this is the first landmark in the evolution of humankind of medicine. In the 50,000 years of humankind, just 50 years ago, that humans could actually peek into the human body without having to open it up. Now, I'm sure this has really transformed medicine in the ways of technology, because all the way medicine was practiced in the past was based on a patient who comes with something, and the patient is examined by the doctor. And for the first time, you can actually peek into the human body without having to open up the human body. And to me, the second landmark is our ability to sequence the genetic material in our genome, genetic material which drives a 37 trillion cell old machine. Now, how are these things being used? In fact, there are some problems that are really worth solving. And I'm sure you've heard in the early sessions how big these problems are. Now, when talking about children with genetic diseases, on an average, children with genetic diseases take 5 to 7 years, or in countries like India, even more, in some cases, even decades before they can even get to a diagnosis. A significant number of children actually die before they reach the 5th birthday. And in fact, 33% is estimated of critically ill infants in the NICU die before even getting a diagnosis. Now, why should we change this? Because we need to change this because a significant number of these children today can be treated with an effective medication or managed very well to be inclusive members in the society. Now, let's just take, for example, something that is very known, metabolic disorders of the newborn. They are quite very well treatable today. A significant number of them at least are at least the most prevalent of them are at least treatable today. They cause considerable numbers in mortality, but unrecognized, undiagnosed. They cause considerable morbidity, leading to intellectual disability or global developmental delay. And of course, there's a lost opportunity because it's treatable only if you can diagnose them very early on. Now, why doesn't diagnosis really happen? Because one, they're not suspected. Second, we don't have the tools to diagnose them very effectively. And third, there is considerable amount of investigations that happen which loses in time and space and of course money before they can even be diagnosed. Now, when we talk about genetic diagnosis, today we use multiple modalities of genetic diagnosis. I'm sure you would have heard about almost all of these. On one end of the spectrum, you have chromosomal karyotyping, or which looks at the chromosomal level abnormalities. Then you have techniques like FISH, chromosomal microarray, and so on and so forth. Then you have PCR based techniques, you have panel based sequencing, and you have on the other end capillary sequencing. Now, all of these are looking at genetic variations, but different resolutions of genetic variations. On one end, you are looking at millions of base pairs of chromosomal abnormalities. On the other extreme, you are looking at single base pair genetic variations. And of course, in between forms all the other kinds of genetic variations. Now, the real problem is here. You are using multiple tools, you are using multiple techniques. Each of them requires very different expertise, very different methods of doing, very different turnaround times, very different cost. And in, of course, almost all patients, you do one or more of these. Now, that has changed at least in the last 2 decades. And that change has largely been what we call as a convergence in genetics. And the convergence in genetics is that you can actually cover all of this with one single test. And this one single test is what we call as a whole genome sequence. So in other words, you can look at the entire resolution of genetic events, fast, effective, in one single test. Now, of course, in India, we are able to do this for the last 15 years. In 2009, India was the 7th country to be able to sequence its own human genome, and in fact, the first country in Southeast Asia to be able to sequence. Now, that sequencing has also allowed us to increase the spectrum of utility right from diagnosis to 4 more additional perspectives in our ability to classify a disease, in our ability to manage the disease much better in terms of pharmacogenomics, in our ability to prognosticate, because if you know the genetic variant, you can actually tell when is the severity going to happen, and more importantly, it allows for early diagnosis and intervention, and in some cases at least prevention by carrier screening or prenatal testing. So in one single way, it has transformed the medicine from just diagnosis alone to also 4 other things, which includes classifying, management, prognostication, prediction, and even prevention. Now, this is nothing new. In fact, if you really follow the guidelines in clinical medicine, whole genome sequencing is today the tier 1 test, not the last resort, tier 1 test for a variety of conditions, including the recent American Academy of Pediatrics recommendations in 2025, this year, a few months ago, recommends it's a tier 1 test for GDD, ID, and congenital abnormalities. And of course, there have been recommendations already for these indications from the American College of Medical Genetics, and of course today for the American Epilepsy Society puts it as a tier 1 test for unexplained epilepsy. Now, why is it a tier 1 test? Why the earlier tests were not effective or they were bad? No, the reality is that many of these patients actually lose considerable amount of time to get to a diagnosis, and that considerable amount of time is actually going to cost the window of opportunity for treatment, because a significant number of these disorders are currently treatable. In fact, if you look at global developmental delay, in a country like India, approximately 6 to 8% of children with global developmental delay have a treatable genetic disorder. That means if you could identify them in the early months, they could be perfectly normal members in the society. Unfortunately, they are not, because either we don't diagnose them or we use the right or the wrong tool to be able to diagnose them. The second is our ability to diagnose disease fast. And this is data from this year. This is from the Seattle Children's Hospital. And what they did was very simple. Sometime in May 2022, that is 3 years ago, they decided to stop all the standard of care genetic testing and transition to whole genome sequencing. Now, the standard of care genetic testing in 2022 in the US is pretty much the standard of care genetic testing today that we all use. By just making one decision to transform that to one single test, a whole genome sequencing, they published this paper which came in this year. From a mean time to diagnosis of 289 days, the time to diagnosis came down to 13 days. Now, if this does not really move you, I am not sure what would move you. In fact, in India, we are even much better. We can actually do ultra rapid sequencing. That means you can sequence an individual and get back the report in 48 hours. Now, 48 hours is not time to sequence if you really follow this up. It is time from collection of the sample to delivery of the report, includes the logistics time. And we do this routinely in India for sick children in the NICUs. Now, having said that, what technology can do, the other important question that we need to ask is what is really prevalent? Are we acting on problems which are important, or are we acting on problems because somebody told that is important? Now, how do you really estimate prevalence of disease? In many ways, you estimate prevalence of disease by talking to doctors out there. So, of course, having studied pediatrics, if you go to Professor Ashraf, he would tell me these are the disorders which are prevalent. But in your posting, if you move to cardiology, you will find 10 other disorders which are prevalent. Now, just imagine if you, in a committee, you put in a cardiologist and a pediatrician, they are always going to fight with each other and never ever going to get a consensus. Now, how do we really arrive at a consensus? Because there is no way to normalize this, right? And in fact, if you are a good doctor in a particular specialty, you will end up seeing many more such patients. Like, for example, if you are in ICRA, which has a large kidney center, probably the largest kidney transplant center in this part of the country, you will see people with kidney disorders. Does that mean that kidney disorders are the most prevalent? Probably yes, probably no, but there's no way to adjust for that. And to me, the only way to look at prevalence is to be able to sequence normal people. Now, you might ask me, what does normal people have to do with patients with disease? Very simple. You can have a child with a genetic disease largely when two carriers marry with each other, right? And who are these carriers? Are people in this room, right? Who marry with each other, you have children, and if you have a genetic event, your spouse also has a genetic event, then you have, in a recessive condition, 1 in 4 chance of getting a child with a genetic disease which is recessive. Now, if I can understand what you carry in your genome, then I can pretty much predict, even without seeing a single patient, what is the really prevalent disease in that population. Now, this is population specific because marriage practices are also constrained by caste, creed, religion, and of course, social constructs. Now, if we can do that, you can actually go back to the clinician and tell that this is probably that it is missed by diagnosis and therefore can diagnose and can be treated. Now, I am sure if the clinician is in here, you would completely agree to me is that you would not listen to somebody who comes and says that you are not diagnosing a patient properly or you are missing a patient and therefore the patient is dying. Now, to me, this is possible, and this is possible if you can even have a few thousand odd genomes from a population. I will come to that in a few numbers. And if you can do that, you essentially need to provide only two things. One is a diagnostic. That means how can you diagnose that condition very effectively? Does not need a whole genome anymore, but you can make it very cost effective, and you need to create the evidence to be able to have clinicians diagnose such conditions. I will just probably give you a couple of examples. Now, until 2019, we are not able to do this just because genome sequencing was not available for the population. In 2019, with the Indigen program, which is India's first population scale program, where we sequenced 1,000 odd individuals from cosmopolitan populations around India. 1,000 in a million or a billion people is pretty much nothing, but we can still understand quite relevant problems which are pertinent to the country. Now, I will put one example in here, and this example is from Calicut. And this is a genetic disorder called primary immunodeficiency. I am sure you will not have heard about this condition because these are not taught in medical colleges. Children with this condition do not have a patent immune system and they die to the disease. They die out of sepsis. Now, I studied in the medical college, so in chance meeting with Professor Geeta Govindaraj, I sort of mentioned that we do find a quite large carrier frequency of PIDs in the population. Is it that something that you see? And she said, no, I don't see these conditions. I work on HIV patients, which also are immunodeficiency but acquired, but I've never seen such patients before. So I sort of convinced over the next 3 years, trying to coax her to actually look for such patients. And what we found was even more remarkable, starting from a small program in 2018 to establishing with support with, of course, the government of Kerala, support from a grant from SCRB, and an association or a foundation called FPID, we set up a clinic, set up diagnostic, and started diagnosing patients. And today, this single center is India's largest cohort for primary immunodeficiency disorder. Around 250 odd children diagnosed with primary immunodeficiency disorder, and this is treatable if you give IVIG, which is today given by the government of Kerala free of cost to all patients, and with hematopoietic stem cell transplant, or what we call as bone marrow transplant, which is also provided by government of Kerala with a one-time payment. Today there are children who can live with this disorder. And of course, many more families could now access genetic counseling services, because if you know the genetic mutation, then you can counsel them, and more importantly, you can screen for the newborn child. And the newborn child has 4 full months before the family can decide to either opt for a hematopoietic stem cell transplant or go into IVIG. And given the very high prevalence of the disorder, we are mad enough to actually pilot a newborn screening program, and as we speak today, the few hundred patients have actually gone to the first pilot newborn screening program for PIDs in this state. Now, does it really change lives? The answer is yes. And this patient was actually covered in the week. This was the first child to be born and screened and of course transplanted just because they got the genome in the right time, in the right place. And I think as we move on, many of them would actually become doctors and engineers and very productive members of the society. Now that comes to newborn screening, and of course the process of newborn screening is very well aware to all of you, and what is included in the newborn screening is also very well aware about you. Now the real question is, are we screening for the conditions which are really prevalent? Right? Who said these conditions are prevalent? And in fact, if you really go back, you will realize that some company made a kit, therefore everybody is using the kit. So we ask this very simple question. Let us take the newborn screening concepts in a very different way. Let us look at treatable causes of intellectual disability. Now there are around 80 disorders today which are treatable if you could identify them very early on. So we asked a very simple question: can we look at the prevalence estimates of carrier frequency in the population from the indigent data, and then look at each of these disorders in terms of prevalence estimates, because we can now understand and factor in the marriage practices across the population. And what we show is very stark. Approximately 1 in 11 Indians carry one variant for 37 or 36 odd treatable intellectual disability conditions. And what this would roughly translate is approximately 1% of children born into this country would have a treatable cause of intellectual disability. 1%. Now multiply by 25 odd million children who are born into this country, that's a huge number, which is today missed out because we are not able to diagnose them, because nobody understands that these diagnosis is possible today and these disorders are very prevalent today. Now if you look at the gene list and of course the conditions, I am sure it will strike a chord here. The top candidate is Wilson's disease. I am sure anybody who has passed through Medical College of Calicut would have seen not one, not dozens, probably a Wilson's disease patient every week. Right? Wilson's is a treatable condition. Right? Very treatable condition with a very effective drug and a very cheap drug. It only costs what, 2,500 or 3,000 rupees per month to treat a Wilson's disease child. But do you find a Wilson's disease child which is treatable? Answer is no. Why do we don't find it? Because we don't screen for it. Why don't we screen for it? Because we are screening for something else. Right? Now assume that we could screen for Wilson's disease. Now all those children could have lived a perfectly normal life, in fact without hepatosplenomegaly, without intellectual disability. Now these are the top candidates that we have: Wilson's, PKU, biotinase deficiency, PKU with a point of caveat that is largely prevalent in the northern part of India. The southern part pretty much does not have PKU. I am sure Kerala government had a PKU screening program, ran for a few months and realized quickly that PKU is not present in Kerala and therefore stopped the program. Now what we try to say is that there are many disorders which are 76 times more prevalent in Indian population, which are treatable today in the country, but for lack of a newborn screening program, we are not screening them, and therefore this child do have disability and even a painful death. So we started to change this disease by disease, and this is for Wilson's disease. In 6 months, we could create the globally largest cohort for Wilson's disease in the country. Today we have around 1,000 odd patients screened positive for Wilson's disease through this program that was set up by my colleague Dr. Binu Kumar. We actually created the globally largest databases for Wilson's genetic disease variants, and we also created a very cost-effective, affordable screening tool using next-generation sequencing, which can scale from 100 samples to 3,000 samples in a very cost-effective way for newborn screening programs in the country. We are actually talking to some governments to sort of pilot this out as a newborn screening program, just because this is a very treatable genetic condition. Now, of course, Wilson's disease is not amenable to biochemical screening, right? And in fact, most of the newborn screening programs are phenotypic or biochemical screening programs. And given the number of diseases which are today treatable, it is very unlikely that biochemical screening programs are scalable. In fact, even in the US, there are only around 37 odd conditions which are treatable today, which are screened today. So the real question is, can we really scale the way to screen these individuals? And this concept is quite some time old. And the idea is very simple. If these are genetic diseases to start with, we should be able to sequence these children to figure out what is prevalent, what is penetrant, what is have large evidence for actionability, and more importantly, what is treatable. And treatability also needs to be qualified by an accessible and, more importantly, affordable drug. Because you don't want to tell a parent that you have a genetic disease that will cost probably crore rupees to treat every year, and they're not going to afford. Probably most people in this country are not going to afford. So you need to have a list of individuals or diseases which can be treated using an accessible and, more importantly, affordable drug. And in fact, a lot of programs around the world have piloted doing this, and in fact, the early data for most of these programs have started coming in. And this is one of the largest of those programs called the Guardian program, which was in Boston. Screened around 4,000 odd children, and what they show is that 3.7% of children born do have a genetic actionability on their whole genome sequence. 3.7%. And probably that is the number that we are currently missing because we don't have a newborn screening program. Now, of course, the treatable conditions in the United States might not be the treatable conditions in India. So we need to build consensus on what is really treatable in India. So early this year, we started this program called Genesis. And the idea was very simple. We will ask every pediatrician, cardiologist, nephrologist, so on and so forth, on what is really treatable in your clinic. If a patient comes to you, is it treatable? And the conditions are pretty much constant, which is called the Wilson and Jugner's criteria. Are there prevalent genetic conditions? Are there penetrant genetic events? Is there high evidence of actionability in terms of a guideline? Is it treatable with an affordable and accessible drug? And what we found is that there are around 453 genes linked to 469 disorders which are treatable in India today, right? And with a cumulative population frequency of approximately 2% of children born into this country. So if you today do a whole genome sequencing of every single child born into this country, 2% of them would have a treatable genetic condition which is treatable with an affordable, accessible drug. And increasingly, this list of drugs are coming up, and I'm not sure you have followed this news that the High Court in Delhi has allowed one of the Indian manufacturers for risdiplam to actually break the patent and manufacture this. And what this has really transformed is a 6 lakh rupees month treatment has become 12,500 rupees. Now, the question is not about whether SMA is treatable. It is treatable today because 12,500 is what every government in India can afford to have for a child with SMA. The question is, are we able to find every SMA child? The answer is no, right? Can you tell me what is the prevalence of SMA in the population? It's approximately 1 in 10,000 individuals, right? Now just imagine what are we really missing out, right? Let's keep aside the cost. The cost will come down because courts will rule as long as manufacturers will manufacture. The cost has actually come down, 11,500. Every single child with SMA can today be treated. But are we able to find the SMA child? The answer is no, because we don't have a newborn screening program for SMA. Now, can we really wait for the biochemical newborn screening program for SMA to be added in the government program? Absolutely impossible. It will probably take a decade of time. Now, why I'm saying this is because there's even more something remarkable that's happening around the world, and this is the cost of sequencing. The first sequence was available in 2003. It costed $3 billion to sequence a human genome. And in last 20 years, it has undergone 1 million fold reduction. There's no technology in the last 2 decades that has crashed 1 million fold in the last 2 years, 20 years. And the line that you see there is the price for semiconductors, right? You have a technology which has even surpassed the price crash for semiconductors. And just imagine now if this continues for the next 10 years, right? Whole genome sequencing will reduce by 1 more million fold, right? That will make it accessible, affordable to practically everybody. And in fact, that would mean a lot of things. In fact, I'm not sure you have followed the news. In 2025, NHS plans to sequence every single child born into the country. Every single child. And I'm sure this will also happen in India. It's only a matter of time, and is also going to start the initiative. I think we should look forward to a genome generation where a genome sequence is the right of every child at birth and not really a privilege for only who can afford to have it. Thank you very much, and I can take questions.